بسم الله الرحمن الرحيم. طلبة سنة 6 أبنائنا وأخواتنا، النهاردة إن شاء الله هنتكلم على problem solving about a very important topic in gastroenterology which is upper GI bleeding. في البداية أحب أعرف نفسي لحضراتكم. أنا اسمي دكتور أيمن شمسية، أستاذ مساعد قسم الجهاز الهضمي، وحدة الجهاز الهضمي قسم أمراض بطنة. فكرة البروبلم سولفينج هي فيرتشوال كيس، هي حالة افتراضية فيها كل مميزات الحالة العادية اللي احنا بنفحصها أو الكلينيكال كيس اللي بناخدها في الكلينيكال راوند. بدايه التعامل مع الفيرتشوال كيس هي ان انا بشوف المعطيات اللي الاوثر عاطيها لي. هي هيديني المريض بيانات عنه، هيديني بيانات عن الكلينيكال سيناريو، وهيطلب مني في الاخر ان انا اتصرف ازاي. اذا كان انا الطبيب المعالج، ايه الحاله اللي هعملها، ايه الانفستيشن المطلوبه، ايه العلاج المطلوب كبدايه. Our patient النهارده هو a 44 years old man presented with hematemesis. This patient had a past history of hepatitis C and alcohol-related liver cirrhosis. During the past 2 years, he had multiple episodes of hematemesis and was admitted to the hospital several times complaining of this and was diagnosed as having esophageal variceal bleeding. These frequent attacks happened during the past 2 years. يبقى أول حاجة هبدأ أبص عليها هو البيشنت بتاعي. He's a 44 years old male. الكلينيكال برزنتيشن هيماتيمسس، هعطيني هنت عن الهيستوري بتاع البيشنت ان هو already diagnosed as liver cirrhosis due to hepatitis C and alcoholism، وان هو الاتاكس دي اتكررت. This is not the first attack. These are repeated attacks of upper GI bleeding. هنا هبدا اول حاجه افكر فيها هو what is the differential diagnosis of upper GI bleeding. المريض ده احتمالاته بالنسبه للupper GI bleeding تكون ايه؟ As we all know ان الupper GI bleeding can be classified الى ulcerative GI bleeding and non-ulcerative GI bleeding او variceal GI bleeding and non-variceal GI bleeding. First of all هشوف الكلينيكال سيناريو بتاعي. هل البيشنت diagnosed as liver cirrhosis, hepatitis C, alcoholism. So this is most probably, and he has multiple episodes of upper GI bleeding in the past 2 years. Most probably this patient is suffering another attack of variceal upper GI bleeding. Of course there remains some other possibilities, but the common is common. Upper GI bleeding is in this patient may be variceal. Less commonly it may be due to erosions, ulcers, malignancy, trauma, or vascular disease. So next, patient has a past history of liver cirrhosis and he was treated already with propranolol. Propranolol is a non-selective beta blocker that lowers the portosystemic gradient or the portal pressure. It is used in between the attacks of upper GI bleeding to decrease the likelihood of GI bleeding, of variceal GI bleeding. And during the acute attacks, patient was dealt with variceal obliteration, mechanical way to obliterate the varices by band ligation. But despite this, he continued to require hospitalization for acute bleeding. Several attacks have happened during the past 2 years. 6 months ago, the last attack happened of hematemesis. His acute bleeding, as usual, was controlled by chemical tamponade with octreotide, bolus and IV infusion, and endoscopic band ligation. At that time, he had no encephalopathy, but he had mild ascites. So, this patient is already on maximum dose of beta blocker and frequent admission to ligate esophageal varices, but requires to continue to require hospitalization due to several attacks of bleeding. I think this patient is an end-stage liver disease who requires liver transplant. But before doing liver transplant, patient should be medically controlled. This patient is in need of TIPS, transjugular intrahepatic portosystemic shunt, which is a temporary measure to improve liver functions and improve portal hypertension till the patient is suitable or candidate for liver transplant. Of course, this patient should be abstinent for alcoholism and should be put on the list to search for a suitable donor. At that time, 6 months ago, his bilirubin level was 1.2 milligram per deciliter, which is slightly elevated. Albumin level was 2.2, which is greatly lowered, and the prothrombin activity, as measured by the INR, International Normalized Ratio, was 1.2. His creatinine level was 1.5, which is slightly elevated, and he still drank alcohol on weekends. That's why he was not a candidate or suitable candidate for liver transplant at that time. He was instructed to stop drinking entirely. He was doing well until one day prior to this admission, which he had, or when he had 2 episodes of coffee ground emesis, followed by 1 episode of hematemesis, which was about 1/2 cup of bright red blood. After that, he noted melena but no hematochezia. The clinical presentation of upper GI bleeding may vary greatly from vomiting of blood, passing blood per rectum, or sometimes occult bleeding. Vomiting blood has two presentations, either a coffee ground emesis, which is an acid hematine material formed by the reaction of acid HCl in the stomach with the hemoglobin, which is described usually as a coffee ground, something blackish vomit. Sometimes the patient vomits fresh hematemesis, which may be sometimes mixed with blood clots or food. Blood may trickle down the GI from the duodenum to the intestine and digested to pass as melena, or sometimes if the bleeding is horrible or a large amount, or if the patient has harrying of the small intestine, the patient may pass fresh bleeding per rectum, which is described as hematochezia. Sometimes patient doesn't notice any bleeding but has an evidence of GI bleeding, which is called occult GI, which may be present as anemia of unknown origin or anemia of undetermined etiology, or sometimes the patient has stool test for occult blood, which is yielding positive and without any other possible diagnosis. His past medical history is positive for intravenous drug use 20 years ago, which is certainly the reason he caught hepatitis C. He was heavy alcohol abuse from 20 years ago up to 3 years ago, and hepatitis C, which was diagnosed at 3 years ago. Cirrhosis at that time was diagnosed clinically based on clinical examination, and his first variceal bleed occurred 2 years ago. And as I said from a while, this patient has frequent admissions to the hospital due to variceal bleeding over the past 2 years. His medications included propranolol, as I told you, it's a non-selective beta blocker, spironolactone, which is diuretic used for the treatment of ascites or decrease the likelihood of ascites occurrence, pantoprazole, which is a proton pump inhibitor to secure the stomach against acidity and prevent erosions and ulcers, multiple vitamins to support the liver functions. There was no history of cardiac, pulmonary, or renal disease, and no family history of liver disease. So what to do initially? The first question is what to do initially. Patient presenting like this is let us see the question another way. What is the emergency management of an upper GI bleeding? Of course, patient like this should be evaluated in the emergency department, which we call risk stratification. Is this patient a high risk or a low risk patient? Assessment of risk stratification can be done through comorbidities. If the patient has comorbidities, this is a high risk. If the patient doesn't have comorbidity, this is a low risk. The severity of GI bleeding as assessed by the amount of blood or the amount of bleeding. Of course, the presence of melena adds risk to the patient. Melena plus hematemesis is more risky than hematemesis alone. The assessment of blood pressure and pulse, initially while the patient is supine and then when the patient is standing, is of utmost importance, because it's the very initial sign of volume depletion, of volume loss, like bleeding, is that the patient may have orthostatic drop of pulse and blood pressure. This is earlier sign than having a supine supine hypotension and tachycardia. So orthostatic hypotension and orthostatic tachycardia is earlier than supine tachycardia and supine hypotension. Of course, we don't the patient in the shock stage, because mortality rises greatly when the patient is shocked. Shock may be assessed if the patient have oliguria, if the patient has disturbed mental status, or if the patient has a very slow capillary filling time. So initially, patient should be evaluated in terms of pulse, blood pressure, airway should be secured. Large IV access should be obtained, either 2 peripheral lines or 1 central line with 3-way. Taking blood samples for chemical analysis for liver functions, renal functions, electrolytes, CBC, bleeding profile, and for cross-matching units of blood to be ready for transfusion if needed. So the answer of this question is that physical examination showed normal vital signs while lying down, but postural changes in pulse and blood pressure. So this patient has orthostatic tachycardia and orthostatic hypotension. The number 20 is very important in such condition. If the pulse increases by more than 20 and or the systolic blood pressure drops by more than 20 on standing, this patient has orthostatic changes. Assume blood pressure, supine was 120/80. If the patient stands and gets within 2 minutes blood pressure of less than 100 systolic, this is orthostatic hypotension. If the pulse supine was 80 and on standing the pulse increased to more than 100, this is orthostatic tachycardia. So these numbers are very important. Increased pulse and or decrease of the systolic blood pressure of more than 20. On physical examination, this patient had a palmar erythema and a spider angiomata, which are the marks of chronic liver disease or liver failure. Peripheral pulses were normal. There was no regular venous distension. Heart was normal to palpation, auscultation, and lungs were clear to auscultation. The abdomen was mildly distended. So after finishing the history, the problem crosses to physical examination. Mild distended abdomen, this means the presence of ascites, and the flanks were bulging, ascites of course. There was mild shifting dullness, so by inspection, palpation, and percussion, the patient had evidence of moderate ascites. The spleen was felt 3 centimeters below the left costal margin by palpation. Liver palpation showed a firm edge and irregular outlines. There was no peripheral edema, and the mental status was normal without the presence of encephalopathy. The results of lab investigations show that the patient has a hemoglobin of 7 gram per deciliter. Normal hemoglobin for a middle-aged male is 14 to 16 milligram per deciliter, so this patient has anemia. The blood urea nitrogen, which is a measure of renal function, is 26, and the normal for such a condition is around less than 16. His creatinine is 1.5, stable since 6 months. Total protein is 5, and this is lowered because normal total protein should be no less than 6 to 8 gram per deciliter, of which the albumin should constitute 3.5 to 5.5 of gram per deciliter in such condition. His albumin was 2.2. Bilirubin total was 1.5. Normal should be less than 1. Direct bilirubin, which is the measure of cholebilirubin, should be normally less than 25% of the total, but here it is around 50%. So this is what we call the half and half jaundice or half and half hyperbilirubinemia, which is a mark of chronic liver disease. Alkaline phosphatase was 183 and is elevated. Alanine amine transferase, which is ALT or SGAP, is elevated 145, and AST is 113. The normal numbers or the physiological numbers of ALT and AST are less than 40 to 45. The INR measurement of prothrombin activity is 1.3 and the normal is less than 1.1. So from this chemical assessment or from this lab assessment, we conclude that the patient has an evidence of chronic liver disease with deteriorated or deranged liver functions. Then comes the question, what to do next, or what is the initial management of such a patient? Of course, this patient needs lots of measures, of which the most important and the most urgent is to correct the deranged lab functions. Patient has severe anemia as evidenced by hemoglobin 7. This is a risky level of hemoglobin. This level should be corrected initially. Patient should be secured in terms of hemodynamic stability and patent airways. And as I told you for a while, patent IV access should be obtained. After that, the patient should be prepared for definitive management and definitive investigation for upper GI bleeding. So the patient, what to do then? The question will be answered by immediately replace the volume. Patient should be given volume resuscitation. Does this patient need a transfusion or not? Come back to the levels. Hemoglobin is 7. In any patient who is hemoglobin or whose hemoglobin is below 8, blood transfusion is indicated. Additionally, if the patient has a cardiac problem in terms of ischemia or heart failure, the hemoglobin level should be kept above 10. So if patient has hemoglobin 10 or less while he is cardiac or comorbid condition, this needs blood transfusion. Better to replace with packed red blood cells. If patient is not cardiac or otherwise fat but has volume depletion and blood loss, should keep hemoglobin at the level of around 8 gram per deciliter. Does patient need plasma replacement? Plasma should not be used for replacing the coagulation factors. Instead, if the patient has coagulopathy, plasma should not be needed, should be a replacement for hypoalbuminemia. But in that case, we use prepared or salt-free albumin instead. If the patient has coagulopathy in terms of hypoprothrombinemia, fresh plasma may be needed to correct the coagulation factors. This measure is, this assessment should be done by measuring the INR. If INR is more than 1.5, give fresh plasma to replace the coagulation factors, and if INR is less than 1.5, there is no need to give plasma. Replacing platelets should be done if the platelet count is less than 50,000 per cubic millimeter. If more than 50, there is no need to replace platelets. So for this patient, hemoglobin 7, he needs blood transfusion, and INR is 1.3. There is no need to replace with plasma or to correct with plasma. The patient was immediately given volume resuscitation, blood transfusion, then chemical tamponade. The options are chemical, mechanical, radiological, and endoscopic. 4 options are available to stop active bleeding. The priority of use depends on the let me say the presence and the expertise of each center. For example, for endoscopic management, you need a 24/7 working endoscopy unit with emergency measures. For chemical tamponade, you need the availability of potent IV infusion system. For radiological tamponade, you need a skilled radiologist for intervention in the form of selective angioplasty. And for mechanical, you need to introduce a nasogastric tube, which is called Sangistaken Blackmore tube, and inflating it for no more than 6 hours to mechanically stop bleeding. These 4 measures are usually available in each endoscopy unit or each GI bleeding unit, but the priority of which depends on the presence and experience for each method. That patient had been put on octreotide bolus and constant IV infusion. Within hours, the signs of active GI bleeding all subsided. There were no other attacks of GI bleeding, either hematemesis nor melena. The nasogastric wash cleared and the enema were clear. So that patient is now considered a stable patient with secured airway, stable circulation, blood replacement, general functions or general liver and renal function retained to normal. So this patient should be subjected. In each patient who sustains upper GI bleeding, upper GI endoscopy is indicated, either as diagnostic and or therapeutic. Diagnostic upper GI should be performed ideally within 12 hours of admission to differentiate between the causes of upper GI bleeding or the different causes of upper GI bleeding. As we said from the beginning, this patient is most probably a variceal GI bleeding, but there remains a possibility the patient may be non-variceal GI bleeding. For example, patient may sustain a gastric ulcer, duodenal ulcer, may sustain gastropathy, may sustain other variceal bleeding rather than the esophageal, for example, gastric variceal bleeding or ectopic variceal bleeding. Patient may be or may have developed carcinoma of the stomach or of the esophagus. There remains a possibility of foreign body or traumatic GI bleeding, and of course remains the possibility of coagulation factor defect or other platelet defect that may lead to upper GI bleeding. So performing upper endoscopy may differentiate lots of causes from each other and settles the diagnosis. Of course, this is not the idea beyond upper GI bleeding, beyond upper GI endoscopy only, but patient also may be subjected to interventional GI bleeding maneuvers. Let me say that we can stop bleeding by the endoscope itself. If the patient is actively bleeding variceal esophageal varices, we may do injection sclerotherapy to the esophageal varices. If the condition is less severe with bleeding ceased like this patient, we may do band ligation for the varices. So measures to stop bleeding from esophageal varices may be due to or may be using esophageal injection sclerotherapy, injecting ethanolamine oleate in and around the varices, or band ligation to the actively bleeding varices. If the patient has ectopic varices or gastric varices, this is not dealt with injection sclerotherapy. Rather, we use histoacryl or cyanoacrylate or tissue glue to coagulate the varices. So for esophageal varices, injection sclerotherapy or band ligation. For gastric or ectopic varices, histoacryl injection. For superficial bleeding from gastropathy, we may use the heater probe or argon plasma coagulation. And for ulcerative GI bleeding, we may do injection of diluted epinephrine or superficial cauterization by hot probe or laser to stop active bleeding. So there are lots of maneuvers that may be used to stop active bleeding or to control bleeding in patients with upper GI bleeding. This patient had upper GI endoscopy done about 6 hours after admission, which revealed the presence of a large, non-actively bleeding esophageal varices were seen. This is the endoscopic picture seen during upper GI endoscopy. This is these are the varices. This is varix at around 11 o'clock position. Another varix is at 3 o'clock position, and a third one. Another view of the esophageal varices. This is the esophagus as seen by the upper GI endoscopy. The varices are large, protruding venous channels. This is one, another one, a third one, and the smaller varices in between. So the diagnosis was variceal bleeding. This settles the diagnosis as variceal bleeding. Introducing the scope to the stomach revealed free of all blood and no gastric varices. The esophageal varices were risky in terms of red whale signs. This is a high risk. And there was very mild portal hypertensive gastropathy. To conclude, there was no other sources of bleeding apart from the esophageal varices. So how to deal with these esophageal varices? As I said for a while, if esophageal varices are actively bleeding, the best way to stop is to inject ethanolamine oleate, which is called injection sclerotherapy. If varices like this are not actively bleeding, the best way to deal with is variceal obliteration with band ligation. If the patient had gastric varices, we inject histoacryl or cyanoacrylate to coagulate the varices, and this is not this is used also in either ectopic varices like duodenal varices or distal varices. If the patient has superficial bleeding from portal gastropathy, we may use a heater probe or argon plasma coagulation to control the points of bleeding. Likewise, if the patient has a bleeding ulcer with a visible vessel, we can inject adrenaline around it or use the hemoclaps or hemospray to stop active bleeding. There are lots of measures to stop active bleeding, endoscopic measures I mean, and the use of them depends on the presence and experience of each of them. For such patient, the decision was made to obliterate the varices with band ligation. The band ligation is a mechanical way to stop active bleeding. This is, we suck the varices into the cup. This is what to do then. Then the band ligation is the treatment of a choice. This is the final slide of our presentation. Band ligation was done to that patient. Active bleeding was controlled. The patient was advised to stop drinking alcohol entirely and to keep on treatment like beta blockers and diuretics, and be prepared for TIPS insertion in addition to be a candidate for liver transplant. Hopefully this patient sticks to the treatment, and of course the patient, the final treatment of such condition is a liver transplant. Egypt had the highest incidence of hepatitis C and likely had the highest incidence of liver cirrhosis worldwide. Thanks for the campaign to deal with hepatitis C. Most patients with hepatitis C were diagnosed in early stage before cirrhosis occurred, and treatment or eradication of hepatitis C prevented an epidemic of liver cirrhosis and an epidemic of GI bleeding and an epidemic of hepatocellular carcinoma to occur. Many thanks to the authorities that have allowed eradication of such an endemic problem in Egypt, and this was a very great effort done by the medical staff and the medical council to prevent hepatitis C from being a continual problem in Egypt, which may resulted in lots of cases of liver cirrhosis, bleeding, and subsequently hepatocellular carcinoma. This is the final lecture of the final slide of our lecture. I really enjoyed talking to you, and this lecture will be available for you. Any questions, you can contact the Department of Gastroenterology or contact me directly. Many thanks to your listening. Hopefully this be beneficial to you. And finally, I will thank the Alexandria Faculty of Medicine to allow me this chance to be with my dear students and colleagues of the future. Thank you very much and have a nice time.